Hi everyone. This slide set is going to review some of the common pediatric endocrine disorders. We'll look at the most common things that we see in pediatric settings. Some of these will overlap with the things that we see in adults. Some of them will be quite different. Here's a list of the topics that we're going to at least refer to. Notice on this list that we have diabetes mellitus and thyroid disease with an asterisk because they're important, and we will spend some time discussing thyroid disease. Diabetes, on the other hand, we've already spent an entire unit on, so I'm only just listing it here, reminding you that this is probably a very common endocrine problem that we as nurse practitioners have to deal with. We'll also talk about congenital adrenal hyperplasia, growth failure, and some pubertal disorders. Early detection is really important in endocrine disease for a number of reasons. If we think about thyroid disease, for example, the newborn screening is extremely important because it may determine whether that child develops normally, neurologically, or not. We need to do regular so we have newborn screening available to us as an early detection method. We do regular screening for disturbances of growth and development by following growth very carefully. We want to pay particular attention to the onset of puberty and the progress of puberty because these are both really important indicators that the endocrine system, which controls this area, is intact and functioning normally. So we kind of wait for puberty to see that the endocrine systems that control reproduction are kicking in the way they normally should, and that puberty is occurring the way it normally should. And of course, from an early detection point of view, we want to pick up diabetes mellitus as early as we can, and from that perspective, we try to do a lot of education about the signs and symptoms of diabetes. So in terms of growth monitoring, what do? We do a lot of diligent charting of height and weight in children, and every pediatric visit will have height and weight charted. We'll look at this because the growth of the child is so important in terms of the indications of normally functioning systems, all kinds of systems, but particularly the endocrine system is functioning normally. So you begin to understand why the monitoring of growth is so important in children. You evaluate the pattern of growth. Do this with a growth chart, usually looking at the growth chart to see that the child is following their own pattern of growth, and they may also be following a family growth pattern, which you might want to know about by asking the family some questions about how children in that family normally grow. People may all be very small statured in that family, might be quite tall. Mother might tell you that her kids always grow late, that all of her children were very slender as children, that the women in their family tend to have a late onset of menses, for example. These are all family things that you need to be acquainted with as you do growth monitoring. Puberty is important as a guide to the normal sequencing of reproductive hormones, as we said before. So you should be doing Tanner staging on all adolescents. And from this, the Tanner staging in particular will help you distinguish normal variations from possible pathology. You may not be worried about the girl who's 14 and doesn't have her period yet, because the Tanner staging will tell you that she's not ready for her menses as yet, and the family history may tell you that this is not terribly uncommon. You also might know that there are other things that might be going on that might be delaying this a little bit for this individual. So all of this, the Tanner staging and the family history and the growth patterns, will help you to distinguish normal variations from pathology. So let's go to thyroid disease and start talking about thyroid disease. Newborn screening for thyroid disease is what's most important because the incidence of thyroid disease other than congenital is small in children. So what we have in children is we see congenital thyroid disease, and then in late school age or adolescence we begin to see the onset of other kinds of thyroid disease, particularly Hashimoto's thyroiditis and hypothyroidism. Hyperthyroidism is pretty uncommon in children, pretty rare. So we're going to be talking mostly about hypothyroidism. Then signs and symptoms are similar to what you see in adults, with a little bit of developmental interpretation. So you remember the thyroid is regulated the way most of the endocrine hormones are regulated. There is a stimulating hormone put out by the anterior pituitary, in this case TSH, stimulates the thyroid to produce T4 and T3, produces more T4 than T3, and the T4 is converted to T3 either in the thyroid or in other tissues in the body. And remember that T3 is the metabolically active form of thyroid hormone. Congenital thyroid deficiency occurs about 1 in every 4,000 infants. It's more common in females, and it can have a number of causes. There can be improper development of the gland in the fetus, and this can go so far as to there being complete agenesis of the thyroid gland. I did have a patient in a practice who had no thyroid gland, and she was one of twins, and they were identical twins, but one of them had no thyroid gland and the other one had a very small underdeveloped thyroid gland. So that can occur, but there can also be hereditary enzyme deficiencies that prevent the normal production of thyroid hormone in the thyroid itself. So the thyroid may be normal in terms of its configuration and size, but the enzyme deficiencies may prevent it from functioning normally. So the newborn screening, remember there are some 26 tests that can be tested for in newborn screening. We'll talk about 2 of them here, thyroid, but also congenital adrenal hyperplasia down here, which is done in some states. Quite a few states now do congenital adrenal hyperplasia screening as well. But for thyroid, what they measure, what the little dot measures on that you get off the heel stick, it measures the amount of T4. If that's low, then the TSH is checked next. This test should be done at more than 24 hours of age. In some states they do it twice. They'll do it once in the hospital and then once after the child is discharged, and this sort of covers the fact that some kids are done actually a bit before 24 hours of age. So this newborn screening is extremely important because thyroid hormone is necessary for normal development of the neurologic system, and without it, during this crucial first 2 years of life, when the central nervous system is undergoing so much development, the child will be mentally retarded if they are not supplemented with thyroid hormone. So it's very critical that this can be picked up at birth. If there's any question about the test, then you should be testing the child and doing TSH levels to see whether there's any possibility the child has congenital thyroid deficiency. So what are the symptoms? Prolonged jaundice often in these babies. Remember, they have a low metabolic rate, so they're not going to metabolize that jaundice as quickly either. They're often lethargic, as adults often are who have hypothyroidism. They have delayed stooling and constipation, and they often don't feed well. Again, not so different from what adults show with their pattern of often poor appetite and constipation. They sometimes have coarse facial features. They can have a low hairline in the front or in the back. They often have a hoarse cry, mottled cool skin, also you see in adults. They grow slowly. They often have poor tone, so that they're kind of floppy babies. And floppiness can be indicative of a number of conditions, but thyroid is one of them to pay attention to. They have sluggish reflexes, which adults can have as well when they're hypothyroid. They'll have delayed development, and they will have mental retardation if they are not supplemented. Now let's talk a little bit about managing children who have congenital thyroid disease. They're managed not unlike adults are who are hypothyroid. In other words, their TSH is corrected frequently, is checked frequently, and they are treated to correction of their TSH to a normal TSH level. The difference that you see in children is that they grow, and as they grow they need more thyroid hormone, so that you have to possibly track them a little more carefully than you would an adult who has hypothyroidism, where their need for thyroid hormone is fairly steady. A child's need will be increasing over time. Now remember, we said that other than congenital hypothyroidism, we don't see a lot of thyroid disease in children. But if you do have it, then what are the causes? Well, Hashimoto's thyroiditis in adolescence, and you usually see the beginning of that occurring in adolescence. They can have hypothalamic or pituitary disease, in other words, a secondary hypothyroidism, and it can be idiopathic as well. Children or adolescents who have acquired hypothyroidism would have symptoms that are very similar to adults: an enlarged thyroid, possibly a goiter, slow growth, decreased energy, decreased appetite, constipation, cold intolerance, hair and skin changes that will be very dry. If they're greater than 2 years of age, they will not have mental retardation as a result of their hypothyroidism. So the treatment of these children is not so different than the way you would treat adults. What are the labs in thyroid disease? TSH is the common measure of how well you're doing with treating thyroid disease because of the feedback loop. The problem with T4 and T3 is that they can be protein bound and therefore sometimes a little more complicated to measure. TSH is easy to measure and easy to titrate the dose to get the child to the normal level. The other thing that you will be measuring in both adolescents and adults is antithyroid antibodies. This would be for an autoimmune source like Hashimoto's thyroiditis that would be causing thyroid disease. The treatment is to replace the endogenous thyroid hormone, levothyroxine. The dose is calibrated by the labs, usually by the TSH, and remember that the dose increases with growth. There are a couple of controversies right now in the treatment of thyroid disease. One is whether you should treat with just T4, which is levothyroxine, which is the way we treat in most cases, is to give levothyroxine, which is T4, and then know that the body converts it to T3. There is some discussion about whether it would be more metabolically normal or similar to what our bodies do to treat with a combination of T3 and T4. I think the verdict on that is not in yet. There haven't been any studies that have really supported that as far as I know, so currently most people are treating with levothyroxine. That is the standard treatment. The dose is calibrated by the labs. The question is, to what point do you treat? You remember that a normal TSH runs between about 0.5 and about 4, depending on the lab that's doing the measuring. Used to be that anything within that range was considered normal. When you were treating a patient with hypothyroidism, you got anything in that range, you were okay. But it's pretty well been decided, I think, that the upper levels of normal are really kind of borderline in terms of thyroid function. And so most people these days will treat down so that the TSH is about 2.5 or somewhat below that. So there is still some discussion around that. To what point should you titrate your dose in terms of your lab results? So 2 things to consider as you are out in the practices and seeing how this is managed in the practice where you're working, and would be good to bring back some of that information and talk about it on the discussion board, especially around these two topics. So managing children with thyroid diseases is relatively easy for the most part. Hypothyroidism is not usually difficult to manage in either children or adults. It's a matter of giving them adequate thyroid hormone and then getting their TSH down to a normal range, and then monitoring it sufficiently so that you see that it stays within that range. Kids with congenital hypothyroidism will do very well with adequate thyroid hormone. They will require it for their entire lives, but many adults do as well. It's not a difficult thing to do. It's not difficult to treat or terribly difficult to manage. All right, let's talk a bit about ambiguous gender states. In this world, we're all designated either male or female, and when parents are expecting a new baby, this is much awaited information, either from a sonogram or at birth, as to whether the baby is male or female. It's pretty troubling when a child is born and you're not quite sure whether the child is male or female. There is a condition called true hermaphroditism. These are children who have both male and female reproductive organs, who have a mixture of cell types, some XX and some XY in their body. True hermaphroditism is really quite rare, and so we're not really going to talk about it because it's so rare. Just know that it does exist. Much less rare, though, in fact, the most common cause of an ambiguous gender state is something called congenital adrenal hyperplasia. This is a condition where the adrenal glands are lacking an essential enzyme to produce the hormones that are needed to be produced by the adrenal gland, specifically cortisol and aldosterone. And the hormone that is most commonly lacking the enzyme that's most commonly lacking is one called 21-hydroxylase, but there are others that have been identified too, but they all sort of have the same endpoint to them, and that's that the individual who has this has inadequate amounts of cortisol and aldosterone and too much androgen, misspelled on the slides, but excessive androgen production. As a result of their lack of cortisol and their lack of aldosterone, they have a salt-losing disorder, so that they look somewhat like individuals with Addison's disease. And when they are stressed, they can become hypotensive. They also don't have obviously good regulation of the sodium in the body. This can also result in ambiguous genitalia in females. Now, both males and females can have congenital adrenal hyperplasia. But if you remember the way the external genitalia develop, fetuses early in fetal life have the same genitalia, which basically looks female, and then as a result of testosterone produced by the testicles in the male fetuses develop male genitalia. The females, because of either very small amounts of androgen or no androgen production, develop into females. So in the presence of excessive androgen, the male genitalia will develop normally, but the female genitalia will be masculinized. So the treatment for this is replacement of the missing hormones and then surgical correction for the girls. A lot of family education and support needed around this, as well as post-operative care for these little girls. There's been a lot of interest in studying girls with congenital adrenal hyperplasia because It's thought that some of the brain differences between males and females is a result of the effects of androgen on the developing brain in the fetus. And so because of this, girls with congenital adrenal hyperplasia have been fairly extensively studied to see if they develop differently than boys do, whether their play is different, whether they have different interests. Again, trying to sort of disentangle this whole idea related to gender of how much of being female or male is what we are born with and how much of it is environmental. So there's been a lot of studies over the years of girls with congenital adrenal hyperplasia. So we already said they cannot produce adequate amounts of cortisol or aldosterone, and it is the most common cause of ambiguous genitalia. Males often go unidentified. So the bad part is, for the boys, they don't have any problem with their genitalia, but they may not be identified, so then they have this salt-losing disorder, and they can go into a kind of adrenal crisis when they are stressed because they were not identified. The girls are usually identified because of their ambiguous genitalia. They can also possibly evidence failure to thrive. The dehydration and electrolyte imbalance and lifelong medication is required for these individuals. So here we see the metabolic pathways for the production of these hormones. So we see that the missing enzyme is right here, so that cortisol pathways which result in aldosterone, the mineralocorticoid, and cortisol, which is the glucocorticoid, are both blocked by the lack of this enzyme right here. What happens in these metabolic disorders is not only are you lacking the end product on one arm, but because of the block here, you often have excessive production of another arm of that same pathway. And that's exactly what happens here, so that this cholesterol then all gets cycled up here, and these kids actually have excessive testosterone production. This is a little girl with ambiguous genitalia, so you see here that you wouldn't think it was a little boy, but you might wonder if it's a little girl because of a couple of things. One is we begin to see here some fusion of the labia, and we see these rugae on the labia here, which begin to look kind of scrotal-like, and we see definitely an enlargement of the clitoris here. Sometimes it's more pronounced than this, but it's a good example of congenital adrenal hyperplasia, what it can look like. So let's sum up congenital adrenal hyperplasia. You need to understand what it is. Usually these children are identified at birth. They're sent to an endocrinologist and treated appropriately. However, remember that the boys are not always picked up at birth, and they can have a sort of adrenal crisis. In many states this is tested for in the newborn screening, so you'd want to know whether it was tested for in newborn screening in your particular state. So you might want to find that out. After that, it's a matter of managing the medications. Usually an endocrinologist will manage these kids in terms of their medications, but you at least need to be acquainted with it and know what it is. All right, let's talk about growth failure, failure to thrive. We're always assessing the growth pattern in children, and so you want to be looking at the growth pattern. What is the problem in failure to thrive? Is this child just always been low on the growth curve, or is this child now falling off the growth curve, or what is the issue? Because that will tell you what kind of action you're going to take. Failure to thrive, as you recall when we talked about it in our pediatric lecture, it can be a metabolic problem. It can be a nutritional problem. It can even be an attachment problem. This means that it's it's really hard sometimes to know exactly what's going on when a child isn't growing properly. So you need to assess the parental-child interaction to see if that looks normal. You need to assess the parental knowledge base. You need to get a complete dietary history on this child. Find out exactly what it is they're eating and when they're eating. And the most common organic causes of failure to thrive are renal disease, cystic fibrosis, celiac disease, and I don't have it on here, but the other thing to consider is HIV, if that is a possibility in a child. So the way this is usually approached is that you start off by getting this information, and if nothing is real obvious, you rule out the organic causes of the disease. In other words, you draw the appropriate labs to measure renal function. You might get a sweat test and stool studies to rule out cystic fibrosis and celiac disease. And depending on the age of the child, you would order some sort of HIV test. And I say some sort because you would, of course, need to know if either of the parents were HIV positive. And the age of the child would be really important in understanding what kind of testing you would do. From there, if nothing shows up on the screening for physical problems, then you want to find out with great care exactly what the child is eating, and sometimes what's necessary in order to do this is to admit the child to the hospital where their intake can be absolutely measured for a period of time to see how they are eating if you're just not coming up with any answers. And you will see kids admitted to pediatric units for this kind of monitoring for a period of time so that they have a dietitian working with the family, and the staff are recording everything that the child has eaten off of a tray, or how much formula they've taken, and also noting the interaction between the parents and the child during this period of time. If the child continues not to grow well, then you might need an endocrinology referral to find out exactly why that child is not growing well. Let's talk a little bit about short stature, because we do have kids sometimes that are just short and small in stature. And this can be what's called constitutional short stature. These are kids who tend to grow late, and so they have late growth and late puberty. This is more common in boys than it is in girls, but you'll see this child who often is smaller than their age mates, and then has a very late growth spurt. Sometimes families can tell you that this is a family pattern. I had a nephew, for example, who did almost all of his growing at about age 18 in terms of what we normally think of as adolescent growth. So it does happen sometimes. And there's nothing really wrong with these children. It just happens to be a pattern for their particular growth. Of course, you can have growth hormone deficiency. So when you have a child who does have short stature, it's one of the things you check first is their growth hormone levels to make sure that they're normal. Sometimes difficult to differentiate these two unless there's a clear family pattern apparent. And being short and small is more of a psychological problem for males than it is for females. When you get girls that are small and short in stature, it's not such a big issue, but for the boys it often is a big issue when they are smaller than everyone else. But you have to do check growth hormone levels and then take a really good family history to see if there's a possibility of constitutional short stature. And again, you may need an endocrinology referral for this child to do a little more investigation. All right, pubertal disorders. Now, the onset of puberty and the timing of it is very much a family pattern. So one of the things you want to know is how puberty proceeded in the parents. In other words, did mom or dad have a really late puberty, a very early puberty, that sort of thing, because you may be able to recognize a family pattern there. So that's a normal variation. Mom says, I never got my period till I was 15, then you're not so worried about the daughter who doesn't have her menses at age 14. Another normal variation that you see is some gynecomastia in boys, and a lot of times this is really troubling for boys. At the onset of puberty, there is an upsurge in the androgens, but also in the estrogens, and this occurs in both boys and girls, so that we see a predominance of the estrogens in girls and a predominance of the androgens, testosterone, in boys. But there is sort of a period of increasing levels of both of these during the period of puberty. This can result in some gynecomastia in boys right at puberty, so that they begin to develop a little bit of breast tissue. As they grow, this usually just normalizes and it's not so apparent anymore, but it sometimes can be very distressing for boys. And sometimes can be sufficiently bad that some of these boys will have some correction of it later. Mostly that's not required, but you will see a little of that, and sometimes moms will report to you when they come in, or dads, that their son is really self-conscious about this. I've had kids who didn't want to take their shirts off for their exam because they were really self-conscious about the fact that they had just even a tiny little bit of breast tissue that had developed at the onset of puberty. That is a normal variation, and you can assure them that they're not going to turn into girls, and that this is going to stop, and that as they grow it's not going to be very apparent anymore. Now, a real disorder is precocious puberty. In other words, that's puberty before 8 or 9 years of age. There can be multiple causes to this, and for that reason you should refer it to an endocrinologist. It's very important to treat it, though, because it will produce premature closure of the epiphyses and will reduce the final growth or the final height of a child who experiences precocious puberty. So if you begin to see signs of puberty very early, then you should get an endocrinology referral for that child. If they are starting into puberty very early, they can do some things that would delay that or slow that down because it can have a bad effect on their final height in the end. So that's one end of the spectrum, and the other is delayed puberty. So you see puberty quite late. We do know that the onset of puberty is 1 to 2 years later in boys than it is in girls. We'll look at the Tanner staging in just a minute. But for delayed puberty in girls, always consider exercise as a possibility, especially in a child who's doing a lot of running or a lot of intense exercise. Gymnastics and running are both sort of famous for that. Also consider anorexia as a cause. Don't forget that there can be normal variations in terms of family patterns. And if you're not coming up with any good reason for why the child has delayed puberty, again, you might want to refer this to the endocrinologist to see if they can isolate any cause for it. So what is Tanner staging? Pubertal change occurs on a continuum, but for description it's divided into 5 stages commonly called the Tanner stages. The described changes are external signs of normal development of the endocrine system as the child matures sexually. In other words, you are using the secondary sexual characteristics to tell you what's going on with the primary sexual characteristics. And the primary sexual characteristics are the growth of the reproductive organs and the increase in levels of the reproductive hormones. But the secondary sexual characteristics can give you important clues to that. So in females, the changes described are the growth and development of the breasts, physical growth, the development of pubic and axillary hair, but usually pubic hair is what's staged in Tanner staging, and then menarche, the onset of menses. In males, the changes that are described in Tanner staging are the growth of the testicles, the growth of the penis, the development of pubic hair, and physical growth. So here we see Tanner staging for females. So we see that this is the growth spurt that you see in females. So if you looked at the average, you would see a big growth spurt in a lot of females around age 12. But you can see that this is kind of the normal range here. So anything from about 11 to 14, it says actually 9.5 to 14.5, that you see a growth spurt in females. You see the breast budding occurring often right at the beginning of this growth period, as well as the development of pubic hair. So that these are the Tanner stages, and so you see stage 2, 3, 4, and 5. This usually occurs between about 8 and 13. And then pubic hair developing along that sort of same range, a little bit behind the breast growth, between about 8 and 14. So in girls, the thing you're usually going to see first is a little bit of breast budding as your first sign of puberty, and then some pubic hair, then the growth spurt, and after the growth spurt, then you see the onset of menses, usually about stage 4, about Tanner stage 4 is when you commonly see the onset of menses in most girls, sometimes between 3 and 4. Boys, you see the growth spurt here almost 2 years later. So we see the onset of it between 10.5 and 16, and the end of it 13.5 to 17.5. And you see first the enlargement of the testicles, and then this is the genital rating, in other words, the growth of the genital organs, the penis and the testicles here, and then pubic hair. So enlargement of the testicles occurs first, but that sometimes isn't always, that is not always obvious to you. The growth of the penis is more obvious when you're doing an exam. So pubic hair is sometimes the first thing that you'll notice in boys as the beginning of the onset of puberty. And then we see the growth spurt starting here, and then the staging here. Now, I didn't put all the charts up here that show you the different stages of the growth of the breasts and of the pubic hair stages, but that's in Burns. You can have a look at that so that you know what you are looking for in terms of making those decisions about what stage, what Tanner stage the child is in. So that should always be on the chart of any child starting about age 9 or 10. You should be recording whether you're seeing any signs of puberty and giving them a Tanner staging number to indicate that puberty is occurring as it should. Note on the previous charts the differences in the growth spurt between boys and girls, with boys about 2 years behind. All you have to do is look at a class of about 8th graders to see this. The differences in pubic hair development, which is greater than 1 year behind in boys. Note in girls with breast budding and pubic hair development appearing just as the growth begins to accelerate. So we see these things all occurring together. Menarche appearing in the later stages of breast and pubic hair development and after the major growth spurt. Note in boys that growth of the testicles is the first step in maturation, but as I said, that may not be all that obvious to you. The pubic hair development may be the thing that you notice first. All right, so that wraps up our discussion of endocrine issues in children. You can post any questions you have about pediatric disorders on the discussion board or email me and I'd be happy to answer them.